What I wanted to do here this afternoon, and what I was asked to do, was to talk specifically about federal supply chain legislation and the average manufacturer price issue in Washington. I'll start with the average manufacturer price issue. In the Deficit Reduction Act, the Congress decided that it wanted, as you know, to spend less on generic drugs under the Medicaid program. And the provisions that were put into place in the Deficit Reduction Act were modified by the Affordable Care Act provisions to set the upper limits for the amounts that would be matched by the federal government in paying for generic drugs under the state Medicaid programs. The level of the limits in the Deficit Reduction Act were, once they were examined, deemed to be way too low. We had some opportunity in the Affordable Care Act to bring those limits back up. They are still lower than we would like them to be. So what's happened since that time? Well, the federal government put out a notice of proposed rulemaking last April. CMS has been in the process of, and they have about 14 lists that they've done to this point, of putting out into the public domain information about average manufacturer price and what the limits would look like with these new amounts that are being reported by the manufacturers so far as what the upper limits would be. And we have been gratified to see that CMS has been doing this in a stepwise process. They had the authority to do this and implement these provisions the year that the Affordable Care Act was passed in October of that year, and they have not done that. They've done it in a much more considered fashion. But there is a problem here, and we've talked to Cindy Mann, who's the Deputy Administrator for Medicaid at CMS a couple times now. When you look at the limits that are set for AMPs as a result of the Affordable Care Act, and you look at that in relationship to the AACs and the NACDS, the acquisition cost limits that the states are using, and I'll get into that in just a moment, in order to set these upper limits. In many cases, as much as a third of them, they're below what acquisition cost is. So we've talked to the agency a number of times about the fact that when the states are moving to go to AAC, some form of acquisition cost, the agency is also requiring the states to review and update their dispensing fees. But because of the way the statute's structured and how all this plays out, they're not doing it on the AMP side. They're only doing it with AAC. So we've pointed this out to the agency a number of times and are hopeful, we don't know for a fact, but this will be addressed in some kind of final regulation. We expect the final regulation to be out according to the semi-regulatory agenda of CMS that was published by HHS just a few weeks ago, mid-January. The prior date that had been made public was, I think, December 25th or something there, about 4th or 25th. It's almost exactly Christmas Day. So we could see ourselves losing Christmas, but hopefully we'll get into at least next year, and frankly, the longer the agency deliberates on this to get it right, the better shape we're going to be in. The lines of communication, however, are open. At the state level, we continue to see states gravitate to the use of AAC. There have been a number of states that have done this to you: Alabama, Colorado, Iowa, Idaho, Louisiana, and Oregon. And they've also, as I mentioned, adopted an enhanced dispensing fee. In New York, the state is continuing to collect information to set AACs, but they have not made them public as yet. California is not. It still sounds like they want to move to some form of AAC, but they are not currently collecting information. CMS has been requested by the states to step up and is in the process of having done so, posting lists of national average drug acquisition costs. So it could be that more states will move into the space of doing AAC when essentially CMS hands them that information. And my sense is, and Mary's sitting here too, that California, some other states may just like to be handed that information and not have to be able to, have to go out and actually affirmatively produce it for themselves. And then Maryland and Virginia have also both said that they plan to use NACDS. Let me just move on to the federal supply chain legislation. This legislation is really spurred by the fact that in California in 2004, there was track and trace legislation passed by the state of California. It's been modified twice since that time. It would apply under California law to pharmacies starting July 2017. But I think in the working on the implementation of that in California, there's somewhat of a dawning awareness that having for every pill bottle in the United States information on exactly where it has been and where it's going in the supply chain is really going to be very burdensome. It's called a full-blown track and trace system and just doesn't make a lot of sense. So while California continues to move ahead and it frankly has a very important delegation in the Congress is stepping in and trying to legislate in this area for a national federal supply chain regulation approach, which makes sense. I mean, it's not as if you're manufacturing, shipping, and dispensing a prescription within the sole boundaries of one state. I mean, it's got to be, at the end of the day, some kind of a system that works across the country. So the fact, though, that California is pressing this has really pushed Washington to try to move ahead quickly. The manufacturers, and they are, it's usually the way this works, the manufacturers and the wholesalers and the pharmacies, because that's the way the chain works, is the way in which it's implemented. The manufacturers are first up in California to implement, and in the fall they have to begin attesting to the state of California that they can do so. So they have really been pressing, working with us in a coalition in Washington to try to get this done sooner rather than later so that they have a national system and don't have to dig in to try to figure out how to implement California. So we have legislation that's been passed in the House. It was voice voted. It's bipartisan. This is a novelty in Washington at the moment. But I think that there's been a recognition that it's important to address this because of California. We do need a national system, and the consumer advocates why they want more extensive regulation in some cases than the industry thinks makes sense to do and is necessary for patient care. Everybody seems to have gotten to the place, well, yes, let's do this federally. So we've been able to move things along. Both the House and Senate bills, and the House bill was voice voted, as I mentioned, out of the House, provide for federal preemption, very clean preemption of what's going on in California and across other states. So we would have one national standard. The House approach moves to what we call lot level tracing, which is information tracing based on lot and other transaction information that's received in our stores and used throughout the delivery system by the year 2029. And there's a whole series of steps in the process of public meetings and regulations and guidances and opportunities to participate in what this whole system will look like. The Senate, as I mentioned, also provides for federal preemption, but the main difference between the House and the Senate, and the senators have said this is, the chairman of the Senate Health Committee has said this is really something I'm not going to trade away, something we call in Washington the self-effectuating deadline. Without regard to whether or not FDA has actually finished the processes at HHS for the public to fully participate and get regulations out, in 10 years we're going to be implementing this system. The House approach is much more, from a public policy perspective, a stepwise approach which makes sense. Now, having said that, I think in some measure because of the pressure of the senators from California, they just want to know a deadline in which this is actually going to be in place. And one of the key issues that we have remaining here, and it's a bit of a difference between the House and the Senate legislation, is in the House legislation, pharmacies don't have to provide to the Secretary timely lot level information about the lots that are received in your pharmacies until the point at which it's received electronically, which is a much more workable system than having to cull through paper to report. So the Senate requires culling through the paper. The House basically says you don't have to provide that information. There is extensive other information that you do provide in a single document in most cases, but what we are hoping is that working in conference between the House and the Senate bill, we can get the House provision where you provide whatever document that you get, whether electronic or paper, until you receive the electronic lot level information from the wholesalers and the manufacturers with whom you do business. The other major issue we have there, and this legislation kind of happens in two phases. You have this process of essentially providing what those who work in this space call pedigrees in the near term in phase one, and then more electronic use of information and tracing more at the individual unit level. And for that to work for our members, what we have been pressing for is testing something we call aggregation and inference. And aggregation requires manufacturers to aggregate information however they're sending it to you, however the product is being sent to you in a tote or pallet or whatever, that the barcode on there, you can read and infer from that barcode that what's in what's sent to you is there, so that you don't have to open up every pallet, tote, or whatever sent to you and look at every individual pill bottle. Because we've just told members of Congress, considering the fact the billions of saleable units, about 4 billion saleable units going through the delivery system every year, in order to do that down to the pill bottle level doesn't make a lot of sense. That is a conversation that will happen over the next 10, 12 years as FDA and others, once this legislation is passed, try to figure out how to implement it. So our conference strategy is to aggressively support the House on the lot level tracing provisions and to try to work towards more of the House provisions so far as implementation is concerned, the timelines, and then the Senate actually, in working with them on aggregation and inference matters, they suggested it might be a good solution to have there be private sector pilots that the FDA commissioner would have to consider rather than FDA driving everything. And after we thought about it for a while, we thought that made some sense, because then we'll have the opportunity as an industry to work with our trading partners to design projects, to do them timely, not having necessarily wait for government action, and to provide that information in a way that the FDA commissioner would have to consider it in the process of designing whatever ends up at the end of the day to be the federal supply chain approach. So thank you again for your partnership in the States. Thank you for the opportunity to be here. I think that you will be joining us in future years, and if you'd like me to come back again and speak to the group, sign me up. I'm there. Thank you so much.